All right, so we're going to talk about brain tumors. So brain tumors are malignant or benign. It's chapter 57, acute intracranial problems, page 1375. So brain tumors is very associated with intracranial pressure. So I like to talk about it within the same exemplars. So some of our risk factors are exposing to ionizing radiation, genes, previous head injuries, exposure to electronic magnetic field, environmental. So there's many risk factors associated with it, and there's also a differentiation between benign and malignant, but benign can also cause pressure in the head in specific areas and cause increased intracranial pressure. So some of the types are primary, secondary, supraanterior, and and infratural. So I like to talk about. So primary would be your astrocytes, your gliomas, meningioma, acoustic neuroma, pituitary adenoma. So it primarily from the brain. Whereas secondary has most common was like the lungs, the breast, the GI tract. The cancer came from somewhere else and it secondarily landed in the brain. So there's a little bit of a difference. So supraanterior and infratural, the terms are used to describe the location. I need to do more research on that. Supraanterior and infratural. Very interesting. Really helps me to talk this out and see what I'm confused about. So, because I know that there's different manifestations for supraanterior and infratural. All right, so some of the clinical manifestations are seizure, a headache. There's a frontal, parietal, occipital, temporal, cerebellum, and brainstem. Each location, there's different manifestations that come from it. There's nursing assessments that the nurse is going to do, and diagnostics, interventions, complications. That's annoying that I didn't answer that. And that's why I do what I do. Because I realize that there's holes in my, Okay, so we're going to talk about these manifestations, like the seizure. So the seizure is common with glioma and brain metastasis. The headache is common. In the evening, it's going to worsen. So that's something to think about. Your frontal lobe, it's very important to know what each lobe does. So your frontal lobe is the movement, the reasoning, the behavior, memory. I think this is the same as this other slide that I have. I want to make sure. As well. Okay, well, I'm going to talk about it and then I'm going to re-talk about it so we remember it. All right, so in my notes, it says the frontal lobe is the movement, it's the reasoning, it's the behavior, memory, the personality, planning, decision-making, judgment, decision-making, inhibition, and mood. So that frontal lobe has to do with all that stuff. Your parietal is telling left from right, calculations, sensations, reading, writing, speech disturbances. Your occipital is mostly your vision. Temporal is going to be your language, your comprehension, behavior, memory, hearing, and emotions. It's kind of hard to remember temporal versus parietal. I want to see the difference. Telling left from right, calculations, sensations, reading, writing, speech disturbances, and temporal says language comprehension, behavior, memory, hearing, and emotions. So the cerebellum is the balance, the coordination, and fine muscle control. That I understand. And brainstem is the breathing, the blood pressure, your heart rate, and swallowing. So really, the parietal and temporal lobe could be a little bit hard to remember. So as the nurse, I gotta look that up. All right, so as the nurse, there's the basic assessments. So your basic assessments are going to be your level of consciousness, your motor abilities, your sensory. your perception, your integrated function, bowel and bladder function, your balance, your proprioception, all of that, the nurse is going to assess and to see where is that tumor like located, what is getting affected. You want to assess also the patient caregiver, the coping abilities. You want to do a cranial nerve test to see like what cranial nerves are affected. The Glasgow coma scale. So now there's a thing called Babinski sign and Romberg's test. So Babinski, I'm sure it's like when you do the foot thing, but it's not normal for your feet to spread out for an adult. It's normal for a child. So Romberg test, I gotta look that up real quick. That's what I was gonna do for y'all. Romberg test. Okay. It's supposed to test for proprioception, like ataxia gait disturbance. So I guess they close their eyes and they see if they're gonna like fall over, basically. So that's what that's all about. See, what did I say I was gonna? Oh, supra-anterior versus infraterior. Supra-anterior versus supra. Let's see what pops up. So that I know the one that's, I was going to discuss this with y'all. So like infra-anterior is going more into that brainstem. So you want to worry more about that lower stuff. I know it's in my textbook, and that's really important to remember the differentiation between supra-anterior and infraterior. All right, so now some of our diagnostics are going to be an x-ray. So skull, chest, spinal, you're going to see because you're checking for if the tumor is metastasized. Your history and physical is always important. A neurologic exam, as we said, an ICP measurement, vital signs, MRI, PET, that will basically assess for your size, location, and extent of small tumors. A CT scan will detect the location. An EEG is for seizure. A biopsy is really gold standard when it comes to this. Histology is more accurate for diagnosing the type of tumor. So when you get with figuring out how to treat it. Infrascanners, there's evoked studies and labs. So infrascanner tests for intracranial bleeding, evoke potential tests for the stimulus response, and labs could detect metabolic abnormalities such as SIADH. There's also transcranial Doppler. This measures blood flow. So all of that is important before you start treating everything. All right, so some of the complications you're going to see is hydrocephalus can be caused by a brain tumor, as we explained before about with brain tumors. Cerebral tissue perfusion can be affected, increased ICP, dysphagia can be affected. It depends where the tumor is located. So nutrition, radiation, edema can increase ICP from the radiation if that was the treatment. The treatment with corticosteroids, post-operative stuff, you may want to think of hypothalamus damage. There may be hypothalamus damage with post-op, so like maybe diabetes insipidus, SIADH. So SIADH you want to treat with fluid resuscitation restrictions, declomycin, monitoring the labs. Because SIADH, you are retaining too much fluid, basically. So, yeah. And diabetes insipidus, you're losing too much fluid. Treat with fluid replacements, monitor lab values and essential nutrients. So that's basically what's going on with that. And post-operative, you want to think about seizures or bleeding can cause if a complication arises. So now for like the nursing interventions, what are we going to do if the patient had a chas v'shalom, a brain tumor? Nursing focus. What are we focusing on? So what we're focusing on, and I'm going to want to do some case studies to get good at this. So there's an airway, there's neurological status, safety, seizure precautions, administering medications, home care, fostering, independence, highest degree, PT, OT, speech, all of that is the nurse's job. All right, so ventricle shunts, this will help with hydrocephalus, as we explained earlier about the treatment of hydrocephalus. Radiotherapy, chemotherapy, pharmacology, surgical stuff, post-operative stuff. So So for chemotherapy, it's used only for cancer and can help only prevent reoccurrence. So there's different types of stuff about chemotherapy. So there's a thing called Temozolomide, and there's an alert about it. So this causes myelosuppression. So before using it, you recommend that absolute neutrophil counts are 1,500 or more, and platelet count needs to be 100,000 or more to reduce nausea and vomiting and taking on an empty stomach. So then there's methotrexate, there's carmustine, there's bevacizumab. You want to treat these patients with glioblastoma multiforme that continues to progress after standard therapy, targeted therapies that inhibit the action of vascular endothelial growth. So this is a targeted type of medication. So these were just some of the ones that were in the PowerPoint for my professor. Children, vincristine, cisplatin, carboplatin, cyclophosphamide, etoposide. So basically all the cancer drugs. Other things I have on here is intrathecal administration, Visa, and OMA. So this is a big thing. Intrathecal administration is used with Visa and OMA reservoir. So some of the pharmacology is an H2 agonist, preventative, reduce acid, anti-seizure, corticosteroids to help reduce inflammation, antiemetics, promethazine discourage. Promethazine is actually discourage inaccurate neurologic assessment with this one. So that's interesting. And pain, you don't want to use, it says non-opioid. Why is that? I think it's because they're trying to get neurologic assessments, and it's very hard to get a neurological assessment with an opioid. All right, so some surgical stuff, and surgery is to reduce the tumor mass. You want to decrease that ICP, also indicated for abscesses, hematomas. They may have a craniotomy, a stereostatic radiosurgery, a tumor benign curative. If it's benign, it's curative basically, but maybe used with radiosurgery. So post-operative, basically all I have is frequent neurological assessments for the first 48 hours, like LOC, Glasgow scale. You got to look at that. You want to also teach them to avoid straining wide, moving up in bed, and bowels movements. This can increase intracranial pressure also. Head of bed needs to be 30 degrees, and pain needs to be treated. So it really comes down to it's kind of the same concept of all intracranial regulation, pressure stuff. Yeah, and that's everything I know about brain tumors. So happy studying.